Hello, and welcome to Sandwich Seniority. I'm Robbie Haig, your host, and it's my pleasure today to talk with Dr. Louis Molmenti, who is a psychiatrist with REACH. But we will let Dr. Molmenti tell you his story and what he does. Good morning to you. It's a pleasure to have you, Louis.
Thank you very much for having me here, Robbie. It's my pleasure.
It's truly my pleasure.
Thanks.
I think you have a wonderful story that we'd all like to hear about what it is you do and where you do it. So I'll let you speak.
Thanks, Robbie. I'm a psychiatrist and I work at High Point Treatment Center, which is part of the Southern Regional Network. And we offer a variety of services, going from purely detox, going to dual diagnosis, and a purely psychiatric unit, which is the unit I run. We also have different services. We also have shelters, and we have DUI program for people who have been found driving under the influence. So we cover the whole spectrum. My main thing is the inpatient psychiatric unit. That's where I work, and we treat mostly psychiatric patients, but we have a lot of dual diagnosis patients too. Dual diagnosis are patients who have both a psychiatric and a substance abuse history and diagnosis. Mm-hmm. Hopefully, the patients that we receive should always be mainly psychiatric patients who have a drug problem. But sometimes we get patients who are purely substance abuse and they're looking to see if they have some kind of psychiatric diagnosis. Sometimes they do, sometimes they don't. So that's the kind of population we work with. It's mainly younger crowd, anywhere between 16 and 35, 36. That's the average. We have some people older than that, which is mostly the alcoholics. People who do drugs usually by their late 40s, they've either gotten clean or unfortunately they've passed away.
Really?
That's why we have such a low quantity of older people on drugs.
That is amazing.
Yes, it's surprising how many die from overdoses or illnesses related to their drug use.
Sure.
It's very sad, really.
Now, the psychiatric department that you oversee, is it all inpatient?
Yes, we have a 16-bed unit. We are looking to expand it to 19, but it's purely inpatient. 16
is a low number, really, isn't it? Do you have a lot of people who come in on a daily basis to see you also?
No, we only have those 16 patients.
Okay.
The national average for a psychiatrist who works on an inpatient unit is about 9 to 12 patients.
Okay.
Because of the acuity, they're all very acute patients. They're patients who have just come from the street. They stop by an emergency room to get medical clearance, and then they come to us. 16 patients is actually on the high side for one psychiatrist, and that's why I have a nurse practitioner also certified as a psychiatric nurse who helps me.
So where do these people come to you from? Do they come directly from police officers, jail?
No, we get them directly from emergency rooms. Okay. And it's the police or ambulances that take them to the emergency room. Most of our patients are patients that have called 911 because they were feeling suicidal, or their families have called 911 because the patient had a psychiatric emergency. They were either having auditory and visual hallucinations, they were very depressed. A lot of them had suicide attempts, so they were taken to the hospital where they get stabilized. Some of them have spent 3-4 days in an intensive care unit because of the severity of their overdoses. Wow. So once they're medically stable, they send them to us to do the psychiatric workup and make sure they're safe before we discharge them to the street or to a different unit of lower intensity.
So, what is the average length of time that you have the patients with you?
The average length of stay for us is 4 to 5 days. I think the exact number last time we did the math, which was a month ago, was 5.2 days.
Okay.
That's determined mostly by the need. And we also, of course, have to fight with insurance companies that want to have shorter and shorter lengths of stay.
Right.
They want to, they only allow us to keep patients who are actively suicidal. So we have to deal with that too. We always prioritize, of course, patient care. So when we don't feel the patient is ready, we fight with insurance, or we have ways to appeal their decisions. And we can usually keep them long enough for them to be safe. Mm-hmm. If they're not fully ready, we can step them down to a less complex unit where they will slowly get readapted to the outside world. And when we discharge them, we always discharge them with an aftercare plan in place, mm-hmm. which means appointments with psychiatrists, social workers. Mm-hmm. We talk to DC, to the child and department, because many of them have kids that have been taken by DCF.
Oh, okay.
Yes, that's something. A lot of them have DCF involvement because they were using drugs in the house with kids. So DCF takes the kids away from them.
So you're basically discharging them to a significant other or parents or to home, is that true?
Yes. Yes, we discharge them to home or to the other unit, which is more of an open unit and it's completely voluntary. Mm-hmm. But the unit where I work is a locked unit. Patients can't just leave, it's always locked. Some of them are there voluntarily, what's called a conditional voluntary. Because if they try to leave, we can stop them from leaving. We can keep them for 3 days against their will. Okay. And then if we still feel they're not ready, we have to file what's called a civil commitment. We have to send the court paperwork stating why we want to keep them. And then a judge will come to High Point to the unit, and the patient will be assigned a lawyer, and the hospital lawyer and the patient's lawyer get together with the judge, and the judge decides if the patient needs to be committed against his will, or the judge could decide also to discharge the patient. Oh. That's up to the judge's discretion.
Well, the judge must love coming to the patient.
It's very funny because they're all very afraid of walking into the unit.
I wouldn't be surprised.
They come with big guards from the court, and they see the patients and they tend to walk away, or they look for the closest door to get out. No. And most of the patients are not violent. They're patients who are usually wanting to hurt themselves, yes. Not other people.
Sure.
So, but it's very funny to see the judges running, trying to escape from the patients.
And you say most of your patients have dual diagnoses.
Yes.
Yeah.
Yes.
But you do have another unit in the same building. Is that true?
Yes, we have actually 4 units.
Okay.
2 of them are detox, mm-hmm. and then there's one that's purely dual diagnosis voluntary. Okay. And the unit where I work, which is a psychiatric unit, but most of our patients have dual diagnosis. Okay. Probably out of the 16 patients, normally an average of 10 have dual diagnosis. Okay. The other 6 are purely psychiatric patients.
Okay. Do these patients sometimes fake the dual diagnosis to get in?
Yes, they go to the emergency room, sometimes because they're using drugs and they want to detox, they want to come off the drugs. When they go to the emergency room, they're told that if they want a bed for detox, they usually have to wait about a week.
Okay.
So
And of
instead
course, they're making a decision based on right now.
exactly,
In
they
a
want
week, it may change.
exactly. And so they don't. If they go back home and wait a week, they usually change their minds. So what they do is they tell the doctor at the emergency room that they feel suicidal, or that they are hearing voices that tell them to kill themselves.
Okay.
When they tell that to the emergency room doctor, he doesn't have a choice but to commit them on what's called a Section 12
Okay.
and send them to an inpatient psychiatric unit, which takes usually up to 3 days at the most to find a bed. So that's the way they go around the shortage of beds. They lie, they say I'm suicidal, and that gets them in sooner.
But it's also encouraging that they try to commit themselves.
Yes, and that's why we don't give them too much grief when they come to the unit. I ask them, tell me, did you say you were suicidal just to find a bed or because you really were?
Yeah.
And I warn them that I'm not going to take any kind of different action. So they usually tell me the truth, which is good because then I know how to focus their treatment. I focus it on
Excellent.
moving them to another unit sooner. If they're suicidal, then we are more careful. We keep them longer. We make sure they're safe before we discharge them.
In your estimation, do you feel we need more housing for such people?
I think we do, although the ideal treatment would be to reduce the amount of drugs or
Wow.
education, but that's a very long-term project. So
Yes.
at this point, there's a big shortage of beds. And the insurance companies are trying to even cut down further.
Right.
So it's becoming a very serious problem. Shortage of beds for psychiatric patients or patients with substance abuse is not abundant. We are really short on it.
Yeah. And we're talking about younger people too, basically.
Yes.
Wow.
Kids start using drugs when they're 11, 12.
Really?
It's very common. We have a patient that he's 21 now. The first time he went to jail was when he was 7 years old
Oh my.
because he was found at school selling marijuana.
Oh dear.
From then on, it's been all downhill from him.
Sure.
He's graduated from every jail
Oh,
and
my.
prison. It's very sad, yes. And many kids, when they start using drugs, they use it as a way to self-medicate.
Okay.
Because they're depressed, they are going through a tough time, and instead of going to therapy, they try drugs, and drugs makes you forget reality.
Right.
And it puts you in a world out there where everything is fine. Where
So-
there's no good, there's no wrong and right.
Yeah. So I'm getting an underlying feeling that a lot of this is happening in families that the kids maybe just do not feel important.
Yes, exactly. And many of the parents of these kids are substance abusers themselves.
Okay.
So when they're growing up, that's all they see. They see mom and dad either drugged or drunk all the time. They see them stealing to buy drugs.
Yeah.
They don't feed the kids because they use their money for drugs.
Of course.
The food stamps that the state gives them or their disability checks, they all go to drugs.
Wow.
So the kids grow malnourished, sad, with a very poor example of how you behave in life.
Sure.
The standard of good and bad gets completely shifted.
Yeah.
They have to provide for themselves, so they steal food first, then they steal money, and then they go into drugs like their parents. It's very sad to see this. It's
Very sad. So tell me a little about your background in dealing with these kids.
well, I never wanted really to do substance abuse, and I liked psychiatry. And when I started doing psychiatry, it came a time when I had a kidney stone and I had major surgery all within 2 or 3 months. I was given a lot of painkillers and I got addicted myself.
Wow.
The problem was that being a physician, I had the ability to prescribe.
Sure.
So I could prescribe for myself or I could prescribe for other people, but they would then give me the pills. I could prescribe for friends and family and then they would give. So I got addicted to painkillers myself.
Oh, wow.
After a while, I turned myself in. I lost my license. I had to stay out for about 5 years.
Really?
During which I kept going to programs and I kept testing every week to prove that I was clean. So after 5 years of being clean, they reinstated my license with a lot of restrictions at first.
Oh, sure.
A lot of monitoring. I had to constantly prove that I was clean. But I was able to do it. And so I see it from a different point of view now.
Absolutely.
Doesn't mean I'm soft around them.
Oh, I would think that on the contrary.
Yes, I try to
You
tell
know where
them.
they can go.
Exactly. I understand them. I'm not soft, but I understand. So I try to be fair and to do things knowing what it feels like to be in that place. And I found that the basic thing, what yields the best results, is giving the patient a reason to stay clean.
Yes.
Patients don't have a reason to stay clean.
No.
When patients who are on disability, and they get disability because they say I'm depressed or I have pains, so they get supported, but they become wards of the state.
Okay.
So they know that they're going to have a check at the end of the month or at the end of the week anyway. So there's no incentive for them to be clean.
Right.
It makes no difference to them if they're clean or they're used. They know that if they relapse, they just go back to the emergency room.
Oh, sure.
When they run out of money, they go back to the emergency room. They go into treatment for a few days until their next check.
Okay.
And it's very common in the detox units. You find that on the 30th or the 31st of the month, everybody leaves, or at least half of the unit leaves, because they know that night they're going to get their checks.
Right.
By the 3rd or 4th of the month, they're usually all back into treatment because in 2 or 3 days their money's gone with the drugs.
Right.
They have high tolerance to drugs, so they buy a lot. So they go back into treatment on the 4th day of the month, and then they stay, again, the same cycle begins with the next month.
And you say they have a high tolerance for
For the
medication?
Yes, for everything, because their bodies are used to, when you use drugs, at first a small amount will give you the desired effect, but then you need more and more. I know because when I never did drugs, all I did were prescription medications from the pharmacy, but the effect I got with one pill at the beginning, I had to take 25 afterwards.
Wow, that's a lot.
To get a similar effect. And not only that, I had to take them because otherwise I would get very sick.
Wow.
So it becomes a vicious circle. If you don't use, you get sick. And if you use, you want to use more to try to feel something.
You get sick because of the pain that you're feeling without the medication?
No, not so much the pain, but the withdrawal symptoms.
Okay.
When you withdraw from opiates or heroin, you get very, very sick. You get nausea, vomiting, diarrhea, abdominal cramps, severe physical pain, very high anxiety. You feel like you're going to die.
Really?
Which is the difference from alcohol. When you detox from alcohol, or what's called benzodiazepines like Valium, Ativan, you don't get so sick, but you could die. With opiates, you don't die from withdrawals, but you feel like you are going to. So there are much people who use drugs are much more likely to seek treatment when they're withdrawing than alcoholics,
Okay.
because they don't get as sick. And yet alcoholics die
Yes.
from their withdrawals. They have the DTs, seizures, and they can even, they have a very high likelihood of dying.
Like you had said earlier, you don't have too many older people.
And the older people, they're all alcoholics. There's there's very few old people who are opiate users.
Really?
Yeah.
So it's mostly the kids who are taking the drugs, and the
Yeah.
older people,
The older people, the people who use, like I said, people who use opiates, by their 40s, they either get clean or they die.
Oh.
It's very, very sad. Unfortunately, most of them die. But there are some that manage to get clean because they grow up, they mature, they've seen enough, they've done drugs for many years, so they get clean. But many of them never make it to that stage.
Well, speaking of yourself now, when you were addicted, were you working in the medical field?
Yes, at the beginning, yes.
Oh, very good.
I was working.
I say very good, but I mean that you were working.
Yes, I was working in the same place I'm working now.
Right.
They never realized I was using.
Oh,
And it was a place where we dealt with drug users, but
Sure.
nobody picked up on it.
interesting.
I used mostly at night. So during the day I was fine. Or I thought I was fine, because
Yeah.
you're never fine when you're using drugs. It's a very pervasive illness. It takes over your whole life.
So whatever made you decide to come clean?
My mother,
Oh, how nice is that?
she told me, if you continue like this, you're gonna die.
Wow.
So she's actually the one that turned me in.
Is that right?
Yes.
That's really tough love.
Yes, I ended up in a boatload of trouble.
Wow.
Not only with my license, but legally also.
Yeah.
I worked through it all because they understood it was an illness. I still had to pay a price, a very high price. I lost everything I had. All I had worked for many years, houses, cars, everything was gone.
Wow.
But I knew that I wanted to be a doctor again. My family had all worked very hard for me to study, so I couldn't let them down by just giving up to drugs.
Yeah.
So that's why I know that it's motivation that gets you through.
Did you get your medical education here in the
No,
US?
I went to med school in Argentina.
Okay.
And then I trained as a psychiatrist here in Massachusetts at St. Elizabeth's Medical Center in Brighton.
Sure.
It was a very nice experience there. When I finished my residency, I didn't have much experience with drug abuse. But then they offered me a job that was mainly dealing with substance abusers, so I learned a lot. And then after I had my own experience with drugs, then I decided that that's what I wanted to do. That was the best way. That was the way I was going to help people the most.
It's amazing how things come around like that, isn't it?
I would have never thought even when I was training as a psychiatrist, substance abuse was the last subspecialty I had considered. Well, maybe not the last one. The last one was child psychiatry.
Oh, okay.
Yes,
Wow.
no, very few people go into child psychiatry. There's a huge shortage of child psychiatrists nowadays.
I've been reading that, yes.
It's very difficult to work with kids. It's not the children, mainly it's the parents.
Because you have to work with the parents. When
It's
you
all
work with
about parents because they have to give permission for everything.
it. Right.
It's not what the kid wants, it's what the parents want.
Very interesting.
Yes, and sometimes you can't find the parents who are not involved. They send the kid to the hospital, but they never show up themselves.
Really?
So you can't treat a child who needs their parents' permission for everything.
Right.
You can't treat them if their parents are not involved.
Very true.
It makes it very, very difficult.
Sure.
Your hands are tied because if the parents are not there, how do you know what they're going to say yes to or what they won't like?
Sure.
It's very, very difficult. So,
And you can't work independently yourself. You can't do the job you
No.
need to do.
exactly. So child psychiatry was my last option. Substance abuse was just above it.
Okay.
But
So
then,
you got the double whammy, didn't you?
yes, yes. So I got, life took me there.
Yeah. Now, you were saying that when you were abusing, you were writing prescriptions and
Yes,
you were writing prescriptions for family who would turn them over to you?
yes. My mother mainly.
Your mother? Oh, wow.
That's why she knew I was doing it.
Wow. That had to be very tough for you.
Yes, because my mom at the time had breast cancer, so she was very sick.
Okay.
So, and that's why when she turned me in, I went to her and said, thank you.
Nice.
I couldn't take it anymore. I thought I was going to die.
Wow.
Yeah, she saved me. She saved my life by turning me in.
Isn't that wonderful?
Yes. I felt very bad for having to put her in that position because I know she didn't like to have to turn me in.
I'm sure she didn't.
She had no choice. She felt she had no choice, and that's what saved me.
And it's nice that you know she had no choice.
Yes, I appreciate very much what she did, and I'm sorry I had put her through all that.
But that's the way life goes, isn't it?
Yes, yeah, unfortunately it is now.
How do you feel about this marijuana law that they're trying to create or pass through, or?
Marijuana for medical reasons.
Yes.
To be honest, I'm not sure I found that much medical value to marijuana.
Okay.
On the other hand, many people believe that it's the lesser of all evils, that it's not much different than smoking a cigarette. Mm-hmm. It's really a very difficult topic. There are too many opinions, and they all have their valid arguments. Mm-hmm. So it's more a question of each person's. I'm not sure I would authorize it, because once you start authorizing things, then it keeps climbing, then they're going to want heroin for medical purposes. And heroin, you have a lot of bases for medical
Really?
uses.
Really?
It's a very strong painkiller. Mm. So people can say it's the most natural of all painkillers. So that's why once you start going down that road, mm-hmm. it's very difficult to draw the line as to when do you stop.
Yeah.
Which drugs, even cocaine, you can say that in someone who's dying and they have no energy, why not give them cocaine? And in England, they do that in some places. They give them a mixture of cocaine and heroin to calm the pain and to give the patient energy.
Wow.
Once they have a couple of months left to live only.
Right.
But still,
they're certainly not concerned with whether or not the patient becomes addicted.
At that point you don't care if they become addicted. But
right.
if you start doing that with everybody,
yeah.
where do you draw the line?
But like you said, you're not sure of the medical use of marijuana.
I'm not.
Like with the placebo effect, if people think that marijuana is going to make them feel better,
It will.
It will.
Oh yes.
It will.
The placebo effect is one of the most important things.
Right.
With any medication you give a patient, especially in psychiatry, we don't know how the psychiatric medications work.
Right.
We know they work because they were given to 1,000 patients,
yeah.
and 800 of them felt a bit better. But we don't know exactly how they work. So you tell a patient this is going to work, a patient who's depressed, and sometimes telling them this is going to work and having them put a pill in their mouth, that will improve their depression.
Well, we have talked ourselves out here, Louis, and I totally appreciate you being here.
It's been my pleasure. Thank you very much for having me here, Robbie.
Thank you. We have been talking with Louis Molmenti, who is a psychiatrist at Reach Incorporated, and it's just been a pleasure listening to what he can tell us about our society as it is right now. This is Robbie Haig. Thank you for being here with us for Sandwich Seniority, and we hope to see you again real soon.